Technology, eh?
And we are live now.
Good afternoon, everybody, and I'd like to begin by welcoming those members of the public and press who may be watching this live stream of this meeting via the Council's website. Members, you are now aware of the need to keep your video camera switched on for the duration of the meeting unless there are technical issues, and please keep your microphone muted except when I invite you to speak. Please click the raised blue hand function if you wish to ask a question or comment. If we run into any technical problems, I would ask please for your patience, and should this occur, I will declare an adjournment and reconvene when it is possible to do so. Can I remind everybody that all virtual meetings will be recorded and these recordings will be published on the County Council's website. Members, I will begin by calling the names of all members of the committee to establish your presence. Please unmute your microphone and confirm you are in fact here. Councillor Connor.
Present.
You, Councillor Dupre.
Present.
Councillor Reynolds.
Present.
Councillor Hay.
Present.
Councillor Harford.
Present.
Councillor Jones.
Present.
Councillor Netzinger.
Present.
Councillor Smith.
Present.
Councillor Van der Ven.
Here.
East Cambridgeshire District Councillor Ambrose Smith.
Present.
Fenton District Councillor Clark.
Present.
South Cambs District Councillor Harvey.
Present.
Cambridge City Councillor Massey.
Present.
Huntingdonshire District Councillor Wilson, who substituted for Councillor Taverner.
Present.
Thank you. And myself, Councillor Peter Hudson. Thank you. Item 1 on the agenda is the apologies. I'll ask Rob, please, to update us on any apologies.
Yes, apologies for Councillor Jill Taverner, and as already indicated, her substitute for today is Councillor Sarah Wilson.
Thank you, Rob. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest, please? If so, please raise the hand.
Hold on a minute.
Oh, Councillor Wilson, yeah.
Thank you. I'm an employee of Cambridgeshire Community Services. It's item 6. I'm employed by the school immunisation team and now the COVID team. Thank you very much.
Thank you, Rob. Have you noted that?
I have.
Okay. Councillor Massey.
I'm a governor of Addenbrooke's Hospital.
Thank you. Councillor Wilson, you've got a hand raised. Is that an old one? If it is, can you please lower it? Thank you. Item 2 is the minutes of the last meeting. These were circulated by email on the 1st of December, and we are being asked to approve them of the meeting held on the 19th as a correct record. If any member does not agree with this proposal, would you please use your raise hand function now? Thank you. So we're all agreed on that. So that will go forward and I will sign them when it is safe to do so. Thank you. Item 3 is a Health Committee minutes action log. I think we had this on the 1st of December as well by email. I don't think there's any further updates. I'll just check. Rob, is there any further updates? I don't think there are.
No, nothing really to add. A number of the items will be going for discussion at your next chairman, vice chairman and lead member meeting.
Thank you. Has any member got any questions or wish to raise anything on the action log, please? Thank you very much. We'll go on to the next item. Is item number 4. I've been informed by Democratic Services that there are in fact no petitions or public questions, so we'll go straight on to number 5, please. It's a scrutiny paper on Addenbrooke's 3, an update report. There is an expectation that all members of this committee will have read the published report kindly provided in advance of the meeting. Can I please ask the people who are going to present?
People will be putting on. We will probably do another Q&A next week.
Chair, it's Roland Sinker. I'm the Chief Executive at Addenbrooks. It's lovely to see you. So I'm going to start off, and then I'm going to hand on to Claire Stoneham. Claire, could you just say who you are?
Yeah, there's something on in the background. I think it's on your own feed. Oh, thank you.
Thank you. Thank you. Roland, hi, you're very welcome. Thank you. Can I just remind everybody, please, this has been, because these people are incredibly busy, this is limited to 40 minutes, please. Okay, thank you. Sarah, do you want to introduce yourself?
Yes.
So I'm going to share my screen so that I can drive the pack from here, but I'm going to go on mute because there's other people in my office who are talking. So I'll go on mute and then put the screen share on for the presentation.
Lovely. And as we do that, Sarah, Chair, if I might, just introduce Claire Stoneham and Hugo Ford, who will be presenting after me in that order. So Claire, could you just say who you are?
Hello everyone. Hi, I'm Claire Stoneham. I am the Director of Strategy and Major Projects at CUH. Hello.
And I'm Hugo Ford. I'm an oncologist and I'm the Head of Cancer Services at CUH, one of the Divisional Directors.
Lovely. And Chair, as ever, a huge thank you to you for inviting us along to talk to you. And we'll try and keep our talking quite brief so there's time for questions. And as ever, I mean, Chair, it would be lovely to be with you face to face and look forward to being able to do that again in due course. And thanks for all you're doing. So, Chair, is it okay if Sarah moves on to share the screen?
Yes, please. Absolutely. Yeah.
Lovely. And Chair, would you like me to make a start?
Yes, please.
Lovely. So we were going to cover three areas. So I was very briefly going to talk to you, Chair, and the committee about the status of Cambridge University Hospitals of Addenbrooks and the Rosie. I'm then going to hand on to Claire, who will talk to you about the overall programme that we're exploring on the campus. That obviously has a very, very strong interaction with the local authority, with you, with the population, and with many of our partners in Cambridge Community Services, the CCG, local authority. I could go on. And then I'm delighted to be joined by Hugo Ford, who, as he said, will talk us through the plans specifically for the cancer hospital. You've heard before about the plans for the children's hospital, and then we'll try and draw out some of the areas of that we need to still work on to get to the right outcome. Okay, so if I start briefly, Chair, status update. The position in CUH today is that we have around, I would say, 30 or so patients with COVID-19, a small number of those in critical care. I would contrast that with what we're seeing elsewhere in the country, where some of our partner organisations in Manchester and Birmingham have between 400 and 500 COVID patients in those specialist hospitals in those populations. And what we're seeing in terms of the presentation of COVID to the hospitals on the Cambridge Biomedical Campus here in the south of the county, and obviously we also serve the region, is that that's staying relatively flat. What we're not seeing is that increasing in any material way at the moment. So in that context, we've got a three-part strategy, which we've developed with our staff. We've listened enormously to what our staff and partners have said to us. So the first part of the strategy is to look after patients with COVID-19 and also our non-COVID patients, both locally in the county, but also regionally, in some cases nationally. And if I was to give you the thumbnail sketch on that, we are doing a very good job restarting a lot of our non-COVID services, specialist and sort of planned care, up at now 93% of our pre-COVID elective operating capacity. That's the care we provide in operating theatres. Really good performance in areas like diagnostics. Where we are really struggling and having a pretty desperate time is in terms of the waits that we're seeing in the emergency department. And we are managing that safely and working very, very hard on the flow of patients into the hospital, but also with our partners outside, so we can discharge patients as fast as we possibly can. And that's largely being driven by our loss of around 10% of our bed base to get the hospital configured right for COVID and non-COVID care in a way that's safe. So that's number one. Number two, and the strategy is to keep our staff safe. And in our staff, we think about the 11,000 in Addenbrooke's and the Rosie, but also the additional 15 or so thousand members of staff who are providing healthcare across the county. And we're thinking about that in terms of our role as co-leads of the STP, which will become an integrated care system in due course. So the sorts of things we're working on there are clearly support for mental health and psychological well-being for our staff, how we give our staff space to be able to be socially distanced, a huge drive on the flu vaccination programme, a big programme of asymptomatic testing, 4,000 of our 11,000 members of staff tested last week, and now obviously preparing for the rollout of the COVID-19 vaccine that we hope will start very soon. And then finally is building for the future, and again, listening to our partners and our community. This is about how we work much, much better with colleagues in general practice, social care, community services, the third sector. And we kind of put that in the work we're doing around the STP. And then a huge amount of work going on the Cambridge Biomedical Campus and across the Cambridge life sciences ecosystem, which is crystallising around the hospital builds that Claire will talk about now. So Chair, I'll hand on to Claire. Claire, over to you.
Thanks, Roland, and Sarah. Yeah, thank you. The next slide. So talking a bit about what we're calling our Addenbrooke's 3 programme, and really we're thinking about it in 3 different parts. And the aim of this programme, I think, is to try and make sure that we've got, as far as we can, a sort of coherent strategic direction to how we're thinking about development on the campus, and then some quite clear prioritisation about the order in which we want to do things. So phase 1 is really about focusing on the immediate operational challenges, and Roland's talked a bit about those already. Making sure that we can care for COVID patients safely and effectively, that we've got enough beds in the hospital to be able to look after all of our patients, to try and make sure that the emergency department is fit for purpose going forward, and potentially something as well about long waits for elective treatment. And so looking at sort of different parts to that. So the regional surge centre, we are doing some further building on site to put ourselves in a stronger position to be able to manage a COVID surge if we see one. So that's 60 temporary beds going on to the site, and then 60 kind of more permanent, not permanent, but more permanent, better quality beds that will be connected to the main hospital. And so that's about making sure that we've got enough capacity to try and look after all of our patients through the next period of time. We're also working on a series of proposals to try and strengthen the emergency department, make sure we've got the capacity we need to look after patients that need urgency and emergency and very acute care, and also thinking about the kind of critical infrastructure challenges and making sure we've got a clear set of proposals there. We will need, I think it's fair to say, some more funding from the government to help us address those challenges, but I think really important for us to have a clear and well-developed set of propositions that we're putting forward. So that's the first phase. The second phase is the cancer and children's hospital. Really excited about these developments and the fact that both of them are moving forward at great pace at the moment. With both, we're describing integrated clinical and research hospitals, and with, I think, kind of quite unique propositions, with cancer particularly around early detection, and for children about looking at the whole child and really bringing together mental health and physical health. We've got a huge amount of work to do to really take these from, the ideas are coming together, but we've got to develop the business cases, get even clearer about how we're funding and building these hospitals. And we also need to really think about how we interact as a specialist centre with our kind of fellow hospitals across the region, and making sure that they work really effectively. the other good thing I think about the Cancer and Children's Hospital is they'll allow us to make some changes looking back into the kind of main part of the existing hospital. So again, this is sort of all in line with our strategic direction of improving all of our services over a period of time. And phase 3 really then is going beyond all of the things I've talked about at the moment. We know our main estate is aging. We know it's in increasingly poor condition, even though we do try and do the the most urgent things. So we're really trying to develop a plan for what is the sort of future direction of the hospital. What future developments would we like? Do we think we need to do? With having starting to really think about should that be an acute hospital? What would that need to look like? What would be the types of care pathways and models of care that would allow that to be really well connected into the community, into primary care, so that we're able to look after our local population in a better way in the future. And there are other things that we need to address in that phase 3 as well, in terms of our planned care and other potential areas. So if you can just move on to the next slide. The other thing we thought would be helpful is just a kind of map of the site, and just to sort of see all of these developments where they're located. So hopefully this sort of map is familiar to you all, and you can see the kind of main sort of tower bit of the main hospital sort of in the middle on the right hand side. And you can see Royal Papworth there in the blue colour. So the red dots are where we're placing surge centre beds. So 60 plus 20 of the temporary beds on the sort of upper red colour dot, and another 40 on that sort of lower red dot and the sort of grassy area. Those are extra beds, so we've got them if we need them. The Cancer Hospital in yellow, again on the kind of north part of the site, next to the surge centre. We've got plans for that really starting to come together now. Blue dot is the Children's Hospital, and you'll see, if you know the site well, that's opposite the Rosie Maternity Hospital. So a real connection between those two parts of our estate. And then what we've sort of mapped out with the purple, orange and green dots is the kind of the additional land that we think we've got, and where there's sort of potential further developments I've talked about could go. And what we really need to try and do over the next period, as I say, is be a little bit clearer about what those propositions are and how we would want to implement them over a period of time. I think that's me done, and I think I'm handing over to Hugo.
Thank you, Claire. So in terms of the Cancer Hospital, we are really very excited by this opportunity. We have some key issues which we want to address with this build. The first one is locally, which is that the facilities for our local cancer patients are in some of the oldest bits of the Addenbrooke's Hospital, and a lot of them are increasingly not fit for purpose and difficult to deliver some of the modern therapies that we want to be able to deliver in the future. So just purely locally, that's a vital issue. But more widely, we know that the outcomes of cancer patients in this country, although they're relatively good in Cambridge, in fact, but overall nationally they're very poor compared with other European comparators and other international comparators. And there are a lot of reasons for that, but we think that one of the ways of addressing that is through early diagnosis of cancer. And at Cambridge we have one of the biggest groupings of research scientists into cancer in the country, and indeed arguably in Europe. What we want to do is to focus those people's minds really hard on how we can detect cancer earlier, because quite apart from the outcomes for patients, the costs to the nation of later detection of cancer are very, very significant. And with the cost of cancer care going up much quicker than inflation, we think that the only way really in which we'll be able to afford to provide good cancer care in the future is if we detect more cancers earlier, and if we are also able to focus our treatments on the people who really will need it and will benefit from it, rather than at the moment where we do treat a lot of people who probably we don't know whether or not they're going to benefit, and therefore a number of people are treated unnecessarily as a result. So what we're then, can we bring the next slide, please? So what then we're doing is we're bringing 2 new research institutes into the hospital. One is for the early detection of cancer, and this really is an internationally leading endeavour, because research into early detection is difficult and not very widely done. There are probably only 2 or 3 institutions in the world that are capable of doing it, of which one is Cambridge. And the other one is the Institute for Integrated Cancer Medicine, which is about finding precise and accurate treatments for patients. And the idea is to bring those right into form, as it says in the slide, a harbour joint operation with the high quality NHS clinical services that we have, to ensure that research outputs that these academic centres produce are rapidly translated into patient benefit, and hopefully first for patient benefit for people in Cambridge, but then subsequently more widely for the world. And at the same time, we want to upgrade our local NHS facilities so that we have suitable facilities for the 21st century for treating cancer patients. So, I mean, it says there what will actually be in the hospital. I just draw attention to the fact it's outpatients and inpatients. And one of the things that we will be doing is really focusing on patients who are well, as it were. So information, what we call wellness, exercise, rehabilitation, and also bringing mental health and psychological support into care in a way that we haven't been able to before. So overall, you know, we think this is an exciting prospect. It will give much better environment for people with cancer which are treated in Cambridge, and we hope it will advance the cause of research into cancer, improving outcomes across the country and internationally. And all being well, as you saw from the timeline earlier, we would hope to open this in 2025 or 6.
Yeah. So I think, thank you so much for that, Claire and Hugo. And Chair, we're obviously delighted to engage in any questions. We just put up here some areas that you might want to think about around things like addressing health inequalities across the region, how we can help drive economic growth, what's this going to mean for waiting times, how are we going to develop this in a way that's inclusive and authentic, how are we going to pay for it, and then what's the impact going to be on our local population around things like transport and infrastructure. But I'll hand back to you now, Chair. Thank you. And thank you to Hugo and Claire.
Thank you, Roland. And thank you, Claire and Hugo. Really, really interested. Could you unshare your page, please? Oh, there we all are. Thank you. So, members, we've been asked to note the strategy of Cambridge University Hospitals and make the case for investment in the redevelopment of their ageing estate to enable them to provide facilities that are fit for modern healthcare delivery, and for us to work with them, of course, ensuring that the general public is engaged in the development of the plans. Can I please ask any members of the committee to raise their hand if they want to ask a question, please? Thank you. Councillor Massey. Nikki.
Hi, thank you for that presentation. Obviously, that's not something that I haven't seen before. I do have a quick question, in which case, have you had any input into the discussions and the consultation in regards to Cambridge South Station and its potential location?
Claire, do you want to comment on that?
I'm not sure I know an awful lot about it, I'm afraid, Roland. So,
in that case, I'm happy to. Yeah. So the answer to that is yes. So with so this consultation and push has largely come from the Cambridge Biomedical Campus as a community, and has been led in large part by AstraZeneca on behalf of all of the partners on the biomedical campus. And as a community, we have been very keen to bring that station to fruition, and we reached a consensus as to where we would like it to sit. And there were three options as to where it might sit along the strip between the laboratory of molecular biology and, if you like, the south end of the CBC. And I think we've gone for the site that's closest to the guided busway bridge that comes over the railway.
Great, thank you. Kevin, please.
Right, thank you everybody for the presentation, so very interesting. Hugo, you said there's lots of reasons for disparity in cancer treatment and care in the UK and other countries, and you highlighted early diagnosis. What were the other main areas where we're, as a country, fallen behind?
Well, so the truth is that nobody quite knows the answer to that question, but the areas that people think are important are principally much more about the early identification and diagnosis of disease than they are about later on treatments. So there's certainly some feeling that the culture of people in this country means that they're less likely to seek help from doctors than they are in some other countries at an early stage, and that perhaps the information and education that we give people needs to be better to enable them to identify, symptoms that are problematic. We certainly have many fewer diagnostic machines, as it were, things like CT scanners in particular, per capita than almost any other developed country. And that means that getting people through, even though we have, these waiting times targets, getting people through targets, particularly if they're not, on a pathway, as it were, on a monitored pathway, people do suffer significant delays. I think those are the two main things. There are also some issues with delays to treatment and possibly with some of the hospital treatments that we have, and possibly with people say with fewer treatments for advanced cancer being available. But I think those are much less contributory than the early diagnosis and recognition of cancer. Thank you. Kevin, you happy with that? Do you have any?
Thank you, Chairman. I'm conscious of the time.
Yeah.
So that is one we could explore, but I suspect the gateway into the services is causing a particular problem as well.
Yeah, okay, thanks for that. Lorna, please.
Thank you. I had two questions, but before that, I just wanted to ask a further question about that whole people not seeking help early enough or seeking medical attention early enough. If that is the case, and if that is a significant contributory factor to us falling behind other countries, then what is it that we can do as Cambridgeshire County Council, as a health committee, as one of the partners in all of this? What is it that we can do to assist to turn that around? The other two questions I wanted to ask were, firstly, obviously with the pandemic, there has been much more of a move to virtual consultations where those are possible for some things, at primary care level, and also perhaps possibly at secondary care level. And that has suited some people very well. There are other people that it has not suited very well and who find that quite difficult. And I wondered, it's a very broad question, but how we see that moving forward so as not to create another form of health inequality by making it more difficult for some people to access attention when they need it. And my final question was an estates question about the development of Cambridge University hospitals. And I'm glad that Councillor Massey asked about the guided bus, because my question was about the whole decarbonisation agenda that we're all facing nationally, internationally, everybody. And I wondered to what extent Cambridge University Hospitals was already using and intended to use in future the Clean Air Hospital framework, and whether it has a clean air action plan to address some of those issues.
Shall I take the first two?
Yes, do you want to take the first two, Hugo, and then Claire, are you okay if I take the last one?
So in question to what can the local authority do in terms of early diagnosis, I think that the two things there really that I think we need to work with the local authority on is education, and that is about public information, education in schools, and one of the functions actually of the new hospital will be outreach into the community to facilitate that, and that's from screening programs to things like the Be Clear on Cancer campaigns. We have a situation at the moment where nearly a third of people with lung cancer present as an emergency. And once you've got a lung cancer that's advanced enough to present as an emergency, the chance of curing it are really very small. So these are the sort of things that I think the local authority really could help with, and we'd be happy to talk to you about that. And that's working obviously with Public Health England as well. In terms of virtual consultations, I absolutely agree with you. There's a risk of a sort of digital discrimination and people being effectively cut out of healthcare. At the moment, we're giving about 35% of our consultations virtually, but either by phone or video. All patients at the moment are given a choice of whether or not that is something that they are wish to do, and obviously only a certain number of patients for hospital treatments are suitable for it. That is a little ahead overall of the government target of 25%. My own view is I think quite a lot of follow-up consultations can be seen very effectively in a non-face-to-face way, either by telephone or by video. But I do think we need to be, I absolutely agree with you, very careful that is in line with what people want. And I have to say the feedback that we've had so far has been very good on balance, but you're right to identify that some people do not feel comfortable with a virtual consultation. Can I leave the third one to Roland?
Thanks very much, Hugo. And Claire, you may want to come in on this. So a couple of points. So yes, we do have a plan around sustainability for CUH, which addresses everything from waste to energy use to how people come to and from the site. In all of the new builds that we are exploring, I mean, even if this wasn't the case, we would be doing this anyway. There's a very strong national direction to move towards, it's not quite zero carbon, but net zero carbon enabled is the language that's being used, which is to say we've got to be putting steps in place to enable them to be zero carbon in due course, which is a beautiful set of wording, as you can see. But that's where you get into the sort of concrete you're using, energy use and all that sort of thing. I think that the really big piece, and I think you're alluding to it in your question, and Liz, you may have a comment as Director of Public Health on this, is the real prize here, I think, is how we start to think very imaginatively about how we're looking to keep our citizens well, how we're looking to then care for people without them having to come to the Cambridge Biomedical Campus or to even the GP surgery. And we're looking to redesign pathways that look to keep people well, and when they are poorly, we're able to look after them without all sorts of movement back and forth. So it's a combination of the prevention agenda and how we move people around. And that's, I think, one of the strands that we're working on in terms of our vision for the STP that will become an integrated care system. I'll hand back to you, Chair.
Okay, thank you.
Thank you, Roland. Linda, please. Linda Jones, that is.
Thanks very much. Thanks for your useful answers, particularly the last one, which I was very cheered by, because a vague comment about linking to the local authority is not really what we need to be doing here. I mean, one of the problems, I think, with public health moving out of the NHS is it kind of tends to get forgotten. One of the very, very few benefits, I think, of COVID has been that suddenly everybody realises just how important public health is, and just how important it is to link with them. And the importance of having health in all policies so that people don't need to get to the hospital in the first place, as you say, Roland. So I really welcome that comment. I just wanted to go back, if I could, to pick up Councillor Massey's point, because she's absolutely right about asking about Cambridge South Station. But one of the concerns, I think, I'm involved a little bit with Rail Future, not as a member, so I hadn't got to declare it, but one of the concerns I've picked up from their reports has been capacity issues. And at the moment, the Department for Transport is proposing that there are about 1.8 million passengers going through Cambridge South every year. I think the biomedical campus's own estimate, AstraZeneca's own estimate, is something like 4 or 5 million, and some would put it as high as 7 or 8 million. And I think there's a real concern that the building of this by Network Rail will not actually future-proof the station. And so very quickly, there'll be kind of undercapacity. And I wondered whether, and we've talked a bit to Papworth about this, I wondered whether there is at this point some further input that the biomedical campus could make, not just to think of the station, but to think of the capacity issues in relation to the station, because it is in relation to your staff and not just your patients. I mean, one of the comments been made is that staff could come from a lot further away. Your catchment area, when the station is open, could be a lot further south. So you could generate journeys through having that station open, not just shift movement.
So shall I just offer some observations on that, Councillor? That's what I think. So I'd be very happy to go back to the biomedical campus team and just reassess what we've said in terms of the Cambridge South Station. I mean, some areas of quite live discussion that we're going to want to keep on with. So regardless of what does or doesn't happen with the Cambridge South Station, there are benefits from COVID, which it sounds an extraordinary thing to say. But in terms of things like remote working and recognizing the comments around the ease of use of, for example, remote outpatients appointments, that we're going to want to capture where that's appropriate and not go back on. So not everybody having to come to the campus all of the time. That'd be the first observation. I think the second observation is we sort of want to be, there's help for the campus in terms of it being an easier place to get to. I think the bigger question for all of us is where do we want people to where do we want people to be living and working? So I can see real benefits to the Cambridge South Station, particularly if it's linked up with East West Rail and accessing, or if you like, spreading opportunity and across towards Oxford and through that corridor of Bedfordshire, Milton Keynes. I think that has to be matched by answers to questions around how we reach out into the eastern region with better infrastructure. So the sort of things like that we're offering around apprenticeships at the moment in Addenbrooke's is something that we can offer much more broadly across the eastern region. Because from a strategic point of view, you know, again, Liz, you're at the heart of this thinking in the STP. What we've got to do is think about where the jobs are going to be, where do we want to spread the wealth that sits around a place like the Cambridge Biomedical Campus, because ultimately things like jobs are going to be the biggest determinant of health later on. And I don't think we've got necessarily a full answer on that second question yet. We just need to be a bit cautious about getting sucked into the golden triangle when we have, you know, an enormous amount to do in the eastern region.
Thank you, Roland. Yeah, good answer. And a good question, I have to say, Linda. Thank you. Moving on, please, Susan.
Thank you. I'll first declare an interest as a member of Rail Future, which I never thought of.
Okay, noted.
Thank you very much for the presentation, and especially the map, which I found very helpful in envisaging the future and what really must ultimately be a replacement of the current oldest part of the hospital. I mean, we see plans for specialist hospitals, but ultimately you helped to fill in that puzzle that a general hospital will need to be replaced as well. And you invited us to talk about funding. And could I ask you to talk about the challenges? I know there's a reliance, of course, on fundraising, which we've discussed in earlier meetings, but this must be obviously an important subject.
So Claire, does this occupy any of your nights at all? Would you mind answering that?
Shall I have a go at that? And then you may want to come in. So, and thank you, Susan, for the question. So, if we're particularly thinking about children's and cancer at the moment, because I think those are the two where we've got sort of most developed propositions and some real momentum behind us. What we're doing is asking the government for £150 million worth of funding for the cancer hospital. Alongside that, there's a kind of broader funding package that we're working very hard with our partners to construct that includes the University of Cambridge, because this is an integrated clinical and research facility. There'll be an element of fundraising, and we're really grateful to our partners in QDAR and ACT for all of their support on that. Equally, there may be an opportunity, and we're exploring this quite actively, to bring other partners into the hospital as well. And with any luck, there may be some financial contribution from that as well. The picture on the Children's Hospital is similar. So I'm sure the committee will remember a couple of years ago when the Children's Hospital was given the go-ahead. That came with £100 million of government funding, which really kind of got us off the ground. We've got a very significant fundraising ask to support the Children's Hospital of another 100 million. And again, that is a really fantastic partnership between the university and ACT, and indeed the Head to Toe charity for CPFT as well, kind of really bringing that partnership together. And one of the things we need to do, I think, as we firm up our proposals for children's and cancer, is just be increasingly clear over the next few months how much it's really going to cost us to build these hospitals, to be really clear about the government element of that funding, and then to be increasingly clear about how much is coming from those other pots. But with both of them, they will be very much a kind of partnership efforts. In terms of both the sort of immediate development and the longer term development, I think we've got more work to do to put together really clear propositions on those, and we'll be taking those into a conversation with our regional and national NHS colleagues. I think it's fair to say the capital environment for the NHS is tight. It's been tight for some time, and I think we're not expecting that to change really significantly in the short term. I think for me, it's about being clear about what we need, clear about what we're asking for, clear about the benefits that would come from more investment on the Cambridge Biomedical Campus and into these types of facilities, and being able to run that conversation, so with government colleagues and others. So I hope that helps a bit, Susan.
Thank you.
Thanks.
Thank you, Susan. And last question, please, Lucy. Thank you.
Thank you. A couple of questions. Sorry, Peter. The first one, it is really exciting to see all of this new development coming along. I would just be really interested to know how confident you are about your ability to staff all these hospitals. I think that there's been some concern that the Nightingale hospitals haven't been able to be as effective as people hoped because there simply isn't the staffing available. Clearly, your new surge beds will need staffing. And while the Cancer Hospital and the Children's Hospital are both really exciting and have a sort of 4 or 5 year lead time, actually it takes 4 or 5 years to train specialist nurses and doctors. So my first question is about issues of staffing. It's something I'm particularly interested in. I spent most of 2019 in Brussels, where I had many meetings with the BMA about their concerns over portability of qualifications and the impact of Brexit on medical qualifications. And if those are anything like as bad as they say they are, as they were telling us in Brussels, then I think that staffing for specialist care is going to be an issue. So it would be interesting to know what you had to say about that. Thank you.
Hugo, do you want to offer a view on that?
Well, I think it's a really good question. So the cancer hospital is probably the easiest one to answer from that point of view, because we do have a pretty good workforce plan for that. And in fact, a lot of the work that we're talking about is about making pathways efficient. And in fact, the staffing requirements for the cancer hospital are not very much greater than our current staffing requirements. I think the general point about staffing is very well made. You know, we have we're very lucky in our ability to attract good staff, but it is constantly, you know, something we have to work very hard at to recruit people, and certainly scaling up. I mean, Roland and Claire, I'm sure will come in on this, but scaling up to staff potentially 120 extra beds at short notice would be a major challenge, and we'd have to be very careful about the service models that we were proposing in order to run those properly. In the long run, I think the point about Brexit's absolutely fair. We have, you know, we do recruit internationally from Europe and further abroad, further afield, and we will have to see what impact we have. And we do have plans. The workforce directors have obviously been working very closely and thinking about how this will work going forward. But I don't know if Roland or Claire have anything else to add to that.
Hugo, Claire, any thoughts?
Well, I think you'll probably want to say something about this, Roland, but I mean, we've certainly been focused quite a lot, haven't we, as a trust on recruitment and our vacancy rate. And my understanding is we'd had, that had been quite successful over a period of time with a real focus in that area. I think just the other thing I'd point to that I think we're doing quite well is around things like apprenticeships, and really starting to grow and develop our own staff and creating those opportunities. And I think there is, you know, more that we will want to continue to do in that space.
Yeah, and I think very good summary from Hugo and Claire to the question. I mean, the only two things I'd sort of emphasise is we should all get very, very twitchy and anxious if it looks like we're trying to build what in the end is a much bigger set of hospital infrastructure for the region and the county, unless we can be clear where the patients are going to come from, and that's partnered with really quite radical rethinking around how we look after people, again, going back to keeping people well, and only coming to hospital when they need to. So I can see the hospitals getting bigger, in particular if we're bringing back some of the £450 million worth of activity that goes out of the region at the moment to places like London and Birmingham. And some of those patients shouldn't be travelling that far. But on the whole, small hospital, good, with the right investment in things like public health and out of hospital care. And then the second area I think we need to really test ourselves on is that these are exciting jobs for people. They're hard, but they're fulfilling, they're enriching jobs, they're jobs that give good satisfaction, and we should be trying to make them attractive. And the apprenticeship scheme, I think, is a really good part of that and a good example. The real test is, are we offering those sorts of opportunities to people in some of the areas of greatest need or health inequality or deprivation across the region? And we need to be purposeful about that, not just hop on the plane to go and collect staff, although that is an element that brings enormous strength to the Addenbrooke's family. I think well over 100 nationalities working on the campus, and we want to keep that richness and diversity. So I'd stop there.
Thank you. Lucy, you happy? Any supplementary question, Lucy? You got a couple of seconds.
Well, not really a supplementary, just to say that it is really good to hear about work going on with apprenticeships and training people up from this area, but that's a really long process and a long route. And actually, there's no way that those people are going to be able to help you with your surge beds. So I do think that this is something that we have to recognise is a serious short-term problem.
Okay, thanks, Lucy. Good point made. Roland, Claire, Hugo, as always, it's such a pleasure for you to come to talk to us, and we get such a lot out of it. Can you please take with you, when you leave now, our thanks on behalf of all the members of this committee, and I'm sure on behalf of all the people, our residents who we all represent. A big thank you to you and your staff, the fantastic work you've been doing this past awful year, and we look forward to going forward with you in the future. So thank you all very much indeed.
Lovely. Thank you so much, and goodbye.
Thank you.
Right.
Thank
Good rest of your day.
Thank you, members. We'll move on now, please. Susan, you have a hand up. Would you mind taking it down, please? Still there, Susan? Oh, it's gone. Thank you. Okay, members, we're on, where are we? I was so engrossed with that. Key decisions, item number 6, the recommissioning of integrated sexual and reproductive health service. Val's here, and she'll give us a very brief summary, please. Thank you, Val.
Yes, can I just ask, thank you, Councillor Hudson. Can I just ask Rob if our 2 consultants are waiting in the lobby anywhere? Not yet?
There's
Monica,
no one in the lobby, I'm afraid. Oh, hello. There's no one in the lobby at the moment.
Okay. I'll start.
Yes, can you hear me?
Who are you waiting for, Val?
Hello.
Ruth Derrick.
Sorry.
And someone else you don't know, Kate Turner.
Oh, no. So I can see Raj, but that's it.
Okay. Well, I hope they'll join us. I think they were coming in for 2:30, but we're a little early, so I'll start anyway. Sorry about that. Okay. This paper is about the recommissioning of the integrated sexual and reproductive health services. It's been a bit of a journey in terms of its complexity, because it includes 4 organisations, and it did take quite a time from, let's say, from the vision and then the discussion with all the organisations. We were just about to go out to a competitive tender when, of course, everything was paused because of COVID back in February/March. But however, we know that we need to continue alongside COVID. The world goes on, and we also know that the whole aim of this is to improve services, access to services for people, and to improve the outcomes. Consequently, we have returned to it, and we've also engaged the help of 2 consultants, Ruth and Kate. Ruth Derrick, who you know from the Healthy Child Programme, many members will know, who supported the Healthy Child Programme, and a colleague of hers, Kate Turner, who I hope will join us shortly. This paper has come because as we started to look at what needed to be done in terms of taking this commissioning forward, and also the timeline. The timeline was to have a new service in place from the 1st of April. But however, realistically, to do a competitive procurement, even if we'd started in October, for a service that involved not only quite a complex community sexual health services, which are commissioned by the local authority, but then the additional services from the CCG and NHSE, it seemed to be quite challenging. And this was supported by the intelligence that we were getting back from different services who had been present at the various bidder meetings that we had prior to going out as our planned procurement in last March. And the feedback was that basically COVID was keeping them rather occupied. Most of the organisations are NHS, who had expressed an interest because it is a clinical service. And there was certainly a certain anxiety that these organisations could not fully enter in and do justice to any competitive bid that they put forward. Secondly, one of the purposes of recommissioning the treatment services was that it provided an opportunity to bolster our prevention services. And we have completed the procurement of a prevention of sexual ill health. The savings, which there were some savings that we were going to, or savings, that reallocation of funding from the treatment service to the prevention service. Obviously, this has created some concern, not for this year, but certainly going forward from April, when those planned savings would really be quite critical to the delivery of the prevention service. And the third reason is that to extend again, even for a minimum of 6 months, to enable a competitive procurement to be taken forward, could it was not the preferred legal option, because that would mean extending the contract for basically 2 years from the original contract end. To take this forward, Ruth and Kate, who have now joined us, Ruth I can see, undertook a risk assessment of the options, the risk and benefits of the various procurement options, principally between a procurement process, a competitive procurement process, and a Section 75. And these, this risk assessment very much focused on the feasibility of completing a competitive tender within the timeline and the benefits of a Section 75. And these are detailed in the paper. The appendix actually breaks down each area, but in brief, the preferred option that scored the highest was a shorter term Section 75 that would enable organisations to stabilise through as the COVID situation progresses and hopefully comes to an end next year. And also it would be very helpful for their staff during this period as well. And obviously it would help with the shift of some of the funding to the prevention agenda. Ruth, do you want to say anything about that process? You're on mute, Ruth.
So sorry. Could we just let Kate Turner in? I think she's in the lobby. She's having little difficulty getting in. And she was going to talk us through the process, Val, if that's possible.
Yes, I did. I was concerned about you being out there.
I can see she's appeared on my screen now.
She's on.
Sorry. Kate,
Kate.
Kate, could you just talk us through the process around the evaluation of the risks and benefits of each of the models that we looked at?
Yes, absolutely. So in order to have a clear structure of considering the models without any inherent bias from anybody involved, I applied a general approach to saying what are the things that we're looking for that are really important from a positive point of view, and what are the things that would be very disastrous from a negative point of view. And in the paper it lists which those criteria were, and it applied a weighting, if you like, to each of those. That allowed us as a group then to talk it through and say, okay, do we agree that those are the worst things and the best things? And also, you know, how do we attribute those to the risks and benefits that have already been identified for each of the options? So the options were identified first, and the weightings then were applied, and that gave us a score at the end, which meant that doing it in that way almost takes the inherent bias out of any of us as individuals to go, well, actually, I think this is the right option, because it allows us to go, right, we add it up at the end and we might get a shock. And I use that approach across a number of fields around health and social care, because we have to recognise that as individuals working and existing as human beings, we have inherent bias. So that's the general approach.
Thank you, Kate. By the group, this risk assessment, which Kate just described, the group being NHSE and the local CCG. At the end of that risk assessment, there's an agreement around a Section 75 in view of the current situation, but we haven't yet finalised prior to this meeting the exact length of a Section 75, as there are various issues and concerns which we need to explore further. So the request of the Health Committee is for them to consider the information that's provided in the paper in terms of the procurement options, and to support the establishment of a Section 75 agreement for a short period. That exact term to be defined following further discussion with our partners. I don't know, Ruth, Kate, do you have anything to add?
Could I just add one thing in relation to the potential length of the Section 75? So we had a discussion with stakeholders about what that potential length might be. And clearly there's a significant uncertainty, as we all know at the moment. So we are developing a series of conditions dependent on the outcome of the discussion this afternoon, of course, which would include factors around an assessment of market stability and ability to respond to the ITT if we go out too early. Actually, and providers are not in a position to respond. Clearly, there's a risk to the quality and of the response and to the finances in association with that. Ongoing pressure on local organisations in relation to the COVID response, and I'm talking there about the pressures of the vaccination programme as well as the ongoing pressures of COVID itself. We are thinking that the majority of the respondents to the ITT would be health organisations who could be affected by that. And then the third key condition or factor clearly being the views of stakeholder partners in this integrated procurement.
Thank you, Ruth.
Thank you, everybody. Val, have you finished?
Yes, I have. I think I just to sort of say, as the recommendations are expressed in the paper, and obviously the Health Committee, if you could please consider them.
Thank you. Let's go to questions then, please. Linda Jones, thank you.
Thanks very much. And thanks, Val. It's obviously a complicated process, and you know, clearly it's very welcome that this has been very much a public health assessment type process. It's been very objective and very thorough. And I haven't got a particular issue in terms of the recommendation that's proposed. It may just be me being dim, but I couldn't quite work out the options 2 and 3, which in a way are the kind of two key ones. I couldn't quite work out the difference in benefit score there. The option 2 has got 1 + 5, and I wasn't sure what the 5 referred to. And option 3 has got +4, and I wasn't quite sure what the 4 referred to. So could you, it might be somewhere in the paper, but I couldn't kind of find it. So could you particularly explain what the 5 is? Because negotiating a Section 75 with the current provider for 7 years, you know, I can sort of see the downside of that. I wasn't quite sure where the 5 benefit came from.
Kate, would you like to?
Yeah. In that case, the 5 benefit comes from the stability and the absolute assurance of having something in place from the 1st of April 2021. So the worst case scenario is not having that in place. The best case scenario is we have a well-established secure service in place from that date. So with the 7 years, it would arguably give that assurance and that longevity, which is where those numbers came from. I think within the paper, it's got the description of the scoring quite early on in the paper, and then the bit in the appendix is probably, you almost need to read the first bit, the appendix, and then the scoring, and the flow is slightly better in that way, and that describes which of the things I gave the highest number to.
Yeah,
there was debate.
I did read it, but it still actually wasn't clear, which is why I've asked. And I read the whole paper in the original form, which is when the detail wasn't in the appendix, and I think it's the right place to have put it.
Oh no, absolutely.
It's just you know, it's just being clear about that. I think that's actually, in my view, would be rather a high score for something that is in place in 2021, but then lasts for another 6 years after that. I mean, it seems in a way slightly strange, but anyway, thank you very much for explaining it.
Thank you, Linda. Lorna, please.
Thank you. Yes, similarly to Councillor Jones, I don't have an issue with the recommendation, and I also appreciate the information that we've been given about the risks and benefits and the attempt to kind of score that in some way. I also struggled with the information being in the table and then some further information being in the appendix, and I haven't made a note of it, so I can't point you to it immediately, but I did note that with one of the options there appeared to be more bullet points in the appendix than there were scores in the table, or vice versa. So I wasn't quite sure how they tied up, and it might have been helpful to have had the scores in the appendix for absolute clarity. But that said, I don't think it would have altered the outcome, and I'm not intending to in any way dissent from the recommendation that's being made, other than the recommendation is that that the short period is to be agreed with the commissioning partners, with absolutely no idea of what the short period is. How short is a commissioning period? How long is a piece of string? You know, do we have some idea of that?
I think we're looking for 12 months, aren't we?
Yeah, I think it's anything from 12 months to 3 years, but it could be 12 months or perhaps a little longer.
Sorry, did you say 12 months to 3 years?
Or perhaps 12 to, I think it very much depends when we do the criteria which Ruth described, and how the assessment matches up against those, and to have that discussion with our partners so we can explore quite clearly the risks of doing a shorter one or a little bit or a longer one.
Right, because coming back to that, option 5 is a formal procurement for 2 years plus 1, and that scored the lowest, and I don't dispute that in any way. But what you're now describing as a short period is potentially as long as the whole of one of the potential contracts.
Yes, but I think that the 3-year contract didn't score very highly, I believe.
It was the worst by a long margin.
Yes. And I think but I think with the section 75, I think for a shorter period would get us through this period of COVID, when it is very difficult for provider organisations to really do justice to a competitive bid.
I agree entirely with that, which is why I'm supporting the recommendations. I'm just a little surprised that the short period could be as long as 3 years.
And I think that's a discussion we will have using the criteria which Ruth and Kate have pulled up to explore the pros and cons.
Well, shall we ask Liz to come in, please?
Yes, thank you, Peter. I think that just to support in a sense, the complexity of this, and we absolutely need to score it objectively. We're potentially talking about a period where organisations, many of the community organisations, are also involved in the COVID vaccination programme, for example. So a lot of your bidders would be involved in that. That may go on for quite a long time. This isn't just one service either. This is a service where we're trying to combine services that are separate, that are currently commissioned by 3 or 4 different organisations. So if you risk a sort of quite a long period where bidders couldn't come in, but also even if you do a section 75, you then need time to try to create a good partnership between those different services that you're bringing into one. It is quite complex, and I think we need to look very carefully at how we can just get the benefits of doing this joint commissioning while I'm not doing it for too long a period, because it's just the complexity of the picture does mean that the timescales are not what one might think initially on an intuitive basis, and we need to look at it very carefully.
Yeah, thanks, Liz. That's a bit. I think what we're looking at, the highest score on that table is where we negotiated section 75 with the current provider, which is CCS, of course. That will cover the period until the COVID-19 demands have decreased, and we all hope that will be very, very soon. So perhaps we're looking at 12 to perhaps 18 months. Would you agree with that, Val, Liz?
But we just
I think that's certainly. Sorry, Councillor Dupre.
I'm sorry, we've just been told it could be up to 3 years, which is this is the crux of what I'm trying to get at. I'm not denying the complexity or the benefit of the recommendation. I'm just trying to get to the 3 years surprised me, and now we're being told, Chair, 12, 18 months from yourself.
No. I wasn't telling you. That is my opinion how long it will probably be, and I'm asking for confirmation of that. That will be a probability. But this is just the best way to get a section 75 with a current provider to extend the service until the demands of COVID-19 have decreased enough for us to go out there and do a proper job on getting a new provider. I think that's what we're asking, isn't it?
Yeah, I think we did the initial risk assessment was done around 3 years because this was the type of feedback that we were getting. But I think on further examination does suggest perhaps we could do it in a shorter timescale is feasible.
Yeah, thank you. Linda Jones, please.
Yeah, I want us, I mean, I understand where Councillor Dupre is coming from, but I do want us to be realistic about this. It seems to me that, this is not about when the vaccine's available. This is about the roles that all these teams are going to have in the much longer than we expect rollout of all the vaccines, and the disruption it will cause because people have been seconded, they've been reallocated all over the place. And we know, because we've had it through this committee before, that we've had to have extensions of contract because contracts, even in pre-COVID situation, have not worked out in as timely a fashion as we'd hoped. So I suspect that Val's 3 years, worst case scenario, but actually I think we ought to go in with our eyes open and recognise that may be the length of time that's needed, and everybody hopes it won't be, and that's where that would be the basis on which I would kind of vote for this as well.
And I just sorry, Peter.
Yeah, go on, Val.
No, I think that really echoes my concerns. Is that we go down a route and we really don't know the speed of what's going to happen in this next 12 months, and it's to have that flexibility in a sense. And hence, but do it in a structured way, and use Ruth and Kate's idea of using these very clear criteria to really sort of drill down and say, are we going to be able to achieve this? Because I think at the end of the day, we have a lot of staff who work in this area, no matter what happens at the end of any commissioning process. We have some very highly skilled local clinical staff, and they've had a lot of demands put upon them. And I think that they would appreciate that space to finish what their roles and responsibilities and engage fully with this.
Okay, thanks, Val. Anne, please.
Yeah, to my way of thinking, option 3 and option 5 are totally different, because what they're saying in option 3 is we're negotiating section 75 with the current provider, which would be possible to have in place by April 21. Whereas if we went down the formal procurement route where we let other bidders in, that's why it's scored -5, because the likelihood is that would not be in place by April 21. And that, although they might both be for 3 years eventually, that's why there's the difference in score. So I'm perfectly happy with the recommendations as they are. And I think we have to recognise, even though there may well be the same length of time, they're two totally different options.
Yeah. One's a extension and continuation service. One's to commission a new service. Okay. Are there any more questions, please, before we finish on this? Yeah, Lorna, please. Where are you? Oh, there you are. Yeah. Lorna, your hand's up. Is that?
Yeah. Yes, it is intentionally, Chair, as a point of personal explanation. I feel that it is being suggested that I am suggesting that options 3 and 5 are the same, or that I am opposing option 3. And I want to make absolutely clear, as I've said from the outset, I support option 3. I think the thinking is absolutely right, and I'm not in any way suggesting that those two are the same, or that a 3-year full contract process is desirable. I am intending to support the recommendation, and I recognise the issues that have led to it.
Thank you, Lorna. That's very clear. Thank you for that. Okay, members. So we've got the recommendations in front of us. Recommendation B. If anybody objects to these recommendations, can you raise your hand now? If not, we'll just take them as unanimously agreed. And there are no raised hands, so we will unanimously agree that. Thank you very much indeed.
Thank you.
Thank you, Val, and your team. Thank you, Kate.
Thank you.
Ruth,
Thank you, Hudson.
Right. So, item 7, please. This is public health response to COVID-19. This is, as always, a late report. And the reasons of acceptance of late report are always the same: to allow the report to contain the most up-to-date information and to enable this committee to be briefed on the current situation in relation to Council's response to COVID-19 for those services which it is responsible. Okay, so Liz, it's over to you. Thank you.
Thank you, Chair. And it's only 2 weeks since I last presented the COVID-19 report, and it is quite surprising how much can change over a 2-week period. So in the week ending November 11th, which I presented last time, we were at a rate of 139 COVID cases per 100,000 in Cambridgeshire. And when we move on to the latest reporting week, we're now at 61 cases per 100,000 in Cambridgeshire. And that does show something very important about COVID, which is that it can be a very volatile situation, and the case numbers can change very quickly, both going up and going down. So it's good news that during lockdown, we have seen this fall in cases in Cambridgeshire. Clearly, the lockdown has worked here. And also as part of this picture, the management by the university, Cambridge University, of cases in Cambridgeshire has appeared to work well, because a number of those cases were in the university at the peak. But it is also important to recognise that that early peak we had, that 139 cases per 100,000, did relate very much to behaviours in the week before lockdown, or the few days before lockdown, when it looked as if there was increased socialising before the lockdown actually came in. And that highlights the potential risks that we move into as we come out of lockdown and into the national tier 2 restrictions. I would like to highlight that. It is quite volatile. In terms of our local actions and what's happened in the past 2 weeks, again, I was quite surprised by the amount that we had done over this period. And I think the highlight has to be the launch of the local enhanced contact tracing service across Cambridgeshire on November the 19th. And this is built upon the very successful service model that we had in Peterborough. It's led by environmental health with support from public health, but with close involvement of other staff, because we need the capacity. In Peterborough, basically what it does is to trace the cases who have tested positive for COVID-19 that the national test and trace system has not been able to follow up. So people who didn't respond to those national phone calls or texts, or didn't complete their answers if they did initially respond. And in Peterborough, over time, the Peterborough service managed to follow up 85% of those cases. So it really made a difference in terms of giving the right advice to people who had tested positive for COVID, and finding out who their close contacts were. Those close contacts are then fed back into the national system for follow-up. In Cambridgeshire, we have managed to construct a joint rota across the County Council, the 5 district and city councils, and Peterborough City Council. So this is a huge collaborative effort. It is one team, Cambridgeshire and Peterborough. We're all collaborating, have lots of agreements so that we can support each other's residents, information sharing agreements, and so on. And we are seeing with this model a similar success rate to date of 83% of those cases handed down to us being followed up. And that was, in a sense, an unexpectedly high case rate, because this started when we weren't too far off that peak. So congratulations to all involved, and really pleased to see that implemented right across the area and successful. It also gives us the infrastructure to build our further contact tracing on. We've got a really good team, Cambridgeshire and Peterborough infrastructure around this now. So that's the main thing I wanted to flag. I also wanted to flag something which Val has been working very hard on, quite quietly, but a lot of work going in. And that's a pilot with the Department for Health and Social Care to ensure that some of our most vulnerable residents and vulnerable groups have rapid access to COVID-19 testing. So this is about people who may have drug and alcohol problems, who may be in a domestic abuse hostel, may be homeless. Val has really looked at all those vulnerable groups who she has been leading some work around that in terms of outbreak management, but has this pilot, which has taken a lot of work, getting the clinical leaders in place and so on, so that our vulnerable groups who are maybe at high risk from COVID and spreading COVID can get that rapid access and support to get a test. I would then say that the workload across all our outbreak management cells has continued to be high. Educational cells working very hard, our care home cells working hard, and so on. And our communications have continued to be very active, and that we work very closely across public health and the comms team and community engagement teams. So I'll finish there. I'll just say again, as we come out of lockdown into tier 2, we have a number of risks in December. We have the students coming back from other parts of the country. We have Christmas, and I'm quite cautious on Christmas, but clearly some national guidance that can increase the social mixing at Christmas. So we absolutely need to capitalise and safeguard our success in bringing down the COVID rates during lockdown and have our infection rates absolutely as low as possible when we get to Christmas. I'll stop there.
Thank you, Liz. That's great. Questions now, Lucy, please.
Thank you very much, Liz. It is, as you say, amazing how quickly this the whole situation with COVID changes. I think the first thing I want to say is a huge congratulations to everyone in Cambridgeshire who has worked really hard to get those numbers down and to get the test and trace stuff working. So enormous thanks to all our staff and everybody across all the councils who's worked so hard to get that going and working really well. And also a huge thank you to all the communities who have behaved better during the lockdown, which I think is probably the most important thing in terms of getting the rates down. So I do think it's so important that we thank all of those people. It is also extraordinary that, I mean, I think probably since you wrote this report, new news has come in with the news of the vaccine, which is incredibly welcome news, but it actually is going to be a whole lot more work for public health, the health sector. So in a moment, I wondered if you might tell us a little bit about what you've heard on how that's going to be rolled out. I'm sure that there are lots of plans already kind of coming along in that space. But I think it is also very important that we get the message out that actually getting everybody vaccinated is one hell of a job. My goodness, that's going to be difficult and it's not going to be quick. And that therefore, actually, it's really important that people carry on with the careful social distancing, thoughtfulness about who they're meeting and where they're meeting, and wherever possible, meet outside. All those messages are going to be there for most of us for the rest of the winter, at least. I think we need to be really, really grateful for everything that everybody's done so far. Really grateful that there is potentially light at the end of a tunnel, but it's still quite a long tunnel. So if you were able to say a little bit about that, that would be really helpful. Thank you.
Thank you, Councillor Netzinger. And of course, the vaccine is extremely good news. And I think the Deputy Chief Medical Officer or NHS Director said that he cried when he heard about it, and I think that's probably how we all feel. When we heard it was approved, that was excellent news. But it is going to take some time to bring it in to having a major impact on our population rates of COVID. And clearly the priorities around implementation have been published, and it's around health and care workers and our most elderly vulnerable residents, and then rolling out to other vulnerable groups and ages. So it's great that it's coming in, but It will take time for supplies to come through. The vaccine that's been approved has got very specific operational requirements around it, and the storage temperatures and so on. So I absolutely would emphasise that the NHS will be rolling this out. This is being run by the NHS. We are absolutely offering our support from public health and from the local authorities to make sure that we can help people in the communities be positive about the vaccine, access the vaccine. We can use all our community links to help the NHS with this, but the NHS is leading that rollout and will be very busy with it. And in the meanwhile, it's essential that people understand that we have hope. We have hope for the future. We have hope for the spring. But we are in this marathon, which has been talked about from the beginning, and we absolutely mustn't stop running that marathon, stop doing our social distancing, stop taking all those social measures, which are the main thing that we have until enough people are vaccinated. So I agree, that's an absolutely essential message to get across.
Thank you.
Thank you, Liz. Lorna, please.
Thank you very much. Yes, the news about the vaccine is incredibly heartening. It's just so welcome. But I agree entirely with what the Director of Public Health has said, that you don't stop running when you see the finishing line in the distance. You stop running when you've passed the finishing line. And that is so critically important for us all to remember. But it is really good news to hold on to. And I also just want to say how impressed I've been with the development and the implementation of the local tracing, which has been incredibly successful, and just to offer my congratulations to all involved in that huge piece of work that has really borne fruit, and is something frankly that the government should have been working on from the beginning, but it's great to see it now recognised and being implemented. So huge well done on that. I wanted to ask a question about something that, and I'm sorry, I'm going to do the classic thing that we councillors do. We read something in the newspaper and we ask you questions about it in committee. But I'm going to do it because it seemed to me quite concerning, which was the story a few days ago about care home inspectors not being tested between visits to care homes. And bearing in mind how much care homes have been in the news as hotbeds of infection with COVID. I wanted to ask about that and whether that's been recognised as an issue locally and what is being done about that, because that does seem to me to be a very real point of risk.
Thank you, Councillor. And it's certainly recognised in that locally we have recognised that any professional staff who visit different care homes, there is potentially a risk if people are moving between care homes, then that increases the risk of transmission between those different settings. So it is an issue that we're aware of. I haven't seen that particular newspaper story, so I would be really grateful to have a bit more information about it, Councillor Dupre, and then I can feed back to you or feed back to the committee with some detail against that particular story and the detail of what we are doing to address this.
Certainly, I'll forward that to you after the meeting. Thank you very much indeed.
Thank you. Thank you, Lord. Nikki, please.
Yes, again, thank you for your report. I think it really is heartening not just to hear about the vaccine, but also to hear for our numbers dropping so significantly. And I know there are numbers of caveats there that you've already given about the students returning, etc. But it is heartwarming from a mother with teenagers who are saying, but Mum, all of my friends' parents let their friends come inside their house. Why won't you? Why are you making me freeze? You're so unfair, which is what I get a lot. My concern is that because now we've come out of lockdown, although it certainly didn't feel like a lockdown, it was, and we're into tier 2, I do worry about that complacency of people thinking, well, you know what, we're in tier 2, but it still means that we can still see friends. And what harm does it do if you just pop inside and have a cup of tea? you know, who's going to ask you for proof that you live in the same house if you go to the pub for a Scotch egg, that kind of thing. So I'm wondering about the messaging. I think we know that the issue that we had was with our young people mainly. And so I do wonder about the messaging that we could be asking our schools to have with our teenagers, but also the universities to have to say, when you go home, please act responsible. So that's the first thing. And the second thing is about the vaccine and unpaid carers. I was a carer for a time, and there are huge numbers of unpaid carers out there who are caring for the most vulnerable people who will not be eligible to have the vaccine in the first round, which is a huge oversight, I feel. And I know that we're not national government, so therefore we don't make these rules, but could we perhaps, would you be asking government about these questions yourself? And secondly, could we as the Health Committee be writing to government to ask on behalf of the unpaid carers what their plan is?
Thank you, Councillor Massey. And on your first question about the messaging to young people, I think you're absolutely right to raise this. And what we're trying to do with our messaging from the council, which is thought about very carefully through our comms team working with wider teams, is that we want to emphasise the understanding of COVID. And we know that the highest risk of transmission is in situations where people are indoors, where it's a bit stuffy, not well ventilated, and where it's hard to socially distance at the 2 meters, and people probably aren't wearing masks. And that situation is very much, I think, one about people popping around to other people's houses. Those are high risk situations, and people don't perceive them as high risk because home is the safe place and your friend's home is the safe place. But actually outside for COVID transmission is a much safer place to be. And indoors in the sort of typical family house situation is actually quite high risk, which is why we see so much transmission within families and within households. So a key feature of tier 2 is that you cannot mix indoors with people from other households, and that's whether that's indoors in your own home or indoors in a pub or a restaurant or whatever. So we're really trying to get those messages out about the real risks and the way that infection transmits, so that people understand why these restrictions are there. I think that the messaging to the young people is really important. It has to be, a lot of it has to be about altruism, protecting your loved ones, protecting your community, although there are some people who will have a sequel from a COVID infection in terms of long-term effects on their health. There's a lot about altruism as well. We've looked at the evidence base on this, and it seems that young people often want to do the right thing. They're well motivated, but they often don't trust the same authority figures. They may not trust the government, they may not trust authority. So it's who's giving the message is really important. And for some of them, it's quite hard to actually carry out the behaviours if they are living in accommodation with a lot of other people, or in jobs where they have a lot of sort of public facing work. So it's complex. We are working really hard on our messaging to young people, and happy to bring back more detail on that next time, because it's a key focus of our messaging work. On the unpaid carers, yes, absolutely appreciate your point there in terms of unpaid carers who are with some of our most vulnerable people. It does seem to me that we are in quite a rapidly changing situation, and some of those rapid changes may be about the nature of the different vaccines that may be approved, because it's easier to give some of them in community settings than others. So there is a lot of complexity going on, and I think that if the committee feels strongly about a particular group needing the vaccine, then it's important that you make your views known. The only thing I would say, just thinking from a public health and scientific perspective about the unpaid carers, is that staff working actually in health and social care, where they are exposed to many different older or vulnerable people, and where we know that rates of infection have historically been higher, may be the absolute highest risk, whereas the unpaid carers may be more exposed to one elderly or vulnerable person, but I'm not aware that there's the same basic high rate of infection in that group that we have seen in health and social care workers. So looking at the stats, there may be a case for going first with the people who work in those health and social care environments with lots of patients or lots of vulnerable people. But I do think the unpaid carers are incredibly important. I absolutely agree with you on that, and often not recognised. So I think in that sense, that's an issue that should be raised. And I'm happy to take that back through our local routes and raise it through our local lead for vaccination, who works very closely with the regional, who in turn work very closely with the national, if that's helpful.
Thanks, Liz. That's extremely helpful. Thank you. Susan, please.
Thank you. Could I please add my thanks, Liz, to you and all your team for your continuing amazing work. And continuing on the comms question, I think it isn't just young, we're talking a lot about young people, but Nikki made a very important point, and Nikki, you're not the only one I've heard say it, but for a teenager or a young person to say, all my friends are going to their friends' houses, their parents don't mind. Parents are important too. And I noticed on a radio drama the other day, the adult characters were talking about how much they're looking forward to Christmas and who they're having over, and there was no mention at all of COVID. So there's this cultural feel that Christmas is, you know, we get to have some kind of normal Christmas. And it's just so important to make sure that that messaging is going out to the whole population and not just singling out young people. So I just wanted to make that point, and then also to ask Liz, when you talked earlier about the NHS rolling out the vaccination program, and perhaps this is a question for a different committee, but will the council staff not be contributing? I was under the impression that there will be some role for redeployed staff, just as there has been a role in COVID response to the county-wide hub to the vaccination effort. So I'm happy to take that question outside the meeting if that's more appropriate.
No, I'm happy to respond, Susan. And I think on your first point, you're absolutely right. And that is very acute to identify that the parents and what the parents are allowing their young people to do in terms of household mixing is absolutely key. So I'd agree with you on that. And on Christmas, I think it's people have had such a tough year, and so it's really important that people have something to look forward to, and that they can show that the people that they're close to that you know they care about them, and that Christmas is really important. But and I've said this before, the virus doesn't care whether it's Christmas Day. It's just as infectious on Christmas Day as any other day. So I know a lot of people who are looking to play it safe, and the safest way is a virtual Christmas and virtual communication, and next safest way is outdoors. And there is some risk with indoors, although you can decrease those risks by planning. You can't get rid of them. I also know a lot of people, quite a few people who are planning to have their big family celebrations in the spring or in the summer once that vaccine has had much more of an impact, and are kind of thinking about putting it off. So I think you're absolutely right to raise those points. On the vaccine and the council staff, I think certainly councils and the voluntary sector, everyone appreciates the importance of this vaccine, and you know there are roles that may be needed in terms of marshals, in terms of organising transport. There's all sorts of things that may be needed in order to make sure that people get vaccinated, because for this vaccine to work, everyone who needs it needs to get vaccinated. I think the issue there is that because it's a very moving picture with different vaccines that have different requirements for where and how they might be administered. It's quite hard to pin that down. So what I know is that the councils and the voluntary sector are making these offers of help. We're probably not quite at a stage to pin down yet exactly how those offers will be used, but that communication is in place.
Thank you, Liz. Thank you. And 2 Lindas remaining. First Linda is Linda Harford, please.
Thank you very much, Chairman. First of all, if I may, I do want to add my plea to that of Councillor Massey about the unpaid carers. That is a section of the population whose sacrifice and contribution is absolutely underestimated. A great proportion of those, if they didn't make those sacrifices, the burden would fall on the state. And I think that even if they're not going to be in the very top rung of priorities, I think that we should acknowledge their value by at least having them named as a priority somewhere in that list. So thank you for that. I heard you say too that you supported it. So thank you, Dr. Robin. The other thing I wanted to ask about, I'm sorry, I know I'm always asking about testing, but we all know now that at long last, the government is supporting a move towards residents in care homes being able to have visits from residents at Christmas. And what I'm being told is that that announcement has been made, but there's been no other guidance about how testing will be made available to allow that to happen. Do you have any news whatsoever on guidance coming forward for those providers, please?
I think that's a very good question, which is very hot off the press. And what I will say is that I have been in meetings for most of the day. I have seen coming into my inbox some emails which look like some of that guidance, but I haven't had a chance to look at it, Councillor Harford. So I think it's, I will get back to you after the meeting. I think there is
Thank you. Thank you very much.
Yeah.
Thanks for that, Liz. If you'll be so kind as to let everybody else know that, please, because that's really quite interesting and important for us all. Thank you. Yeah. And finally, penultimately, Linda Jones.
Thank you, Peter. And poor Liz is able to get through your emails. I'm not surprised. I actually want to go back to the paper and just get a few items clarified on there. It's a very useful, very helpful update. In paragraph 3.8, and you talked about this when you presented initially, you talked about the role that local teams are playing in following up and tracing and the high level of tracing you've managed to do. And you then talked about feeding back to track and trace. I was kind of puzzled about what the national track and trace team was actually adding at that point. So that's my first question. The second one was about the fact that in a way, the collapse came quite quickly. So having held out against local track and trace, then a lot of emphasis began to be put on local track and trace. And I just wondered, and other people on the committee might comment on this, I wonder what impact that has had on the city and the districts, because there's quite a stretch there for people. Some of these teams are quite small. Over the past few years, they've been shrunken even more. And the stretch and the strain issue is there. And of course, some people have talked about the vaccine, and there will be another stretch and strain issue in relation to the vaccine. So I'm quite interested in that issue. That's my second question. Third one was, I know we've had a kind of complexity, and I'll put it like that kindly, related to the Cambridge University testing. Is that testing continuing? Because my understanding was it wasn't going to stop and start again. It was going to continue because they were testing not just students, but also staff. So is that still playing into our figures? And the final one, probably the most important one actually, was about Fenland, because I noticed in paragraph 313 that there was a spike in Fenland and there was nothing more about exactly what that was. And I wasn't clear whether that was a community spike, whether it was a spike in some of the processing, factories which you've had in the past. spike among agricultural workers? I wasn't clear. So it would be helpful to understand that. I realise it's coming down now, but to understand that spike obviously is very important going forward. Thank you very much.
Okay, thank you, Linda. And thank you for going back to the paper. So on the local contact tracing, I think I have to make quite clear what we do, which is a very important but quite a limited part of the picture. So the National Test and Trace hand down people who've tested positive to us if they haven't been able to follow them up in 24 hours. Because what you don't want is someone who's tested positive sort of there in the community and no one's got in touch with them to give them the right advice and follow up who they've been in close contact with. So that gets handed down to us in 24 hours, and we use our local knowledge and the fact that we're perhaps offering a local telephone number or a mobile number rather than something that looks like a call centre, national call centre. We use that to follow people up, and most people we follow up by phone. A few we need to go and door knock. So we get in touch with these people, get them the right advice, make sure that they know that they're positive, they know what to do, and gather information on the contacts. But you're quite right, there is limited capacity. So with the contacts, we will then, and we use the national IT systems to do all this. So we're working on the same system as the National Test and Trace. We hand the contacts back to National Test and Trace to follow up. So they do all the work with the close contacts. We do the work with the cases. And that's normally about 20% of cases that the national system can't contact. So that's a very important contribution to do that, but it's limited, and National Test and Trace also plays a big role. So we also follow up with environmental health workplace contacts. Our schools follow up with schools contacts. So it is a sort of mix of local and national. What goes on with contact tracing, but this particular project is quite specific. You're right that it's a stretch. Environmental health officers have different priorities coming at them from all directions, including enforcement, the preventive work with workplaces that Val is very involved with an environmental health officers group, and so on. So with the contact tracing, we have employed extra staff at the county to help with this. We've been at recruitment once to get contact tracing leads. We're going out to recruitment again to put more resilience into that rota. We also have some redeployed staff working from other directorates who are helping with it. And we have the district staff deployed in. So as I say, it is real team Cambridgeshire and Peterborough. We've got lots of different contributions coming in to make it work. And it is a stretch. And that's why we are continually recruiting when we see that stretch getting too much. And we will be recruiting more staff into that. And we'll be building on it. So that is the stretch. The university, we have seen that quite a rapid fall in numbers, and that's good to see. I think they've managed their positive cases very well, ensuring that the infection doesn't spread out into the community. And I haven't got all the detail on your question. What I know is that the testing programme is still going on, and that at the peak they had 234 cases through a mix of asymptomatic and symptomatic testing. In the last week, they have 6 cases, 3 without symptoms, 3 with symptoms. And that programme has gone on. And I know I'm not quite sure of the detail over the holidays. I'm very much assuming they're going to continue with it next term. I haven't heard anything different. So that's the university. Finally, moving to Fenland. What we do, clearly the figures that we get in, we don't have all the detail of the causes of each of the cases. We have seen particular concentrations in Whittlesea and in Wisbech in terms of having more cases in the MSOAs. We know, and Val can perhaps comment on this, but we know that we have a lot of higher risk workplaces in Finland, because we know that these factories which process and pack food are higher risk. They often have refrigerated elements, and we know from other areas. I mean, in fact, I think the feeling is that our links with those workplaces has been quite good in terms of getting in there relatively early with any outbreaks. But we've also seen some cases amongst the older population in Finland, which was of concern to us. Those are coming down now, which is good. So yeah, I don't think we've got one explanation for it. We know that rates are quite high in Peterborough, that they've gone up quite a lot in Norfolk, that they're high in Lincolnshire. So also I think Finland is in that geographical area where we've seen quite a lot of increase. And so you may get some drift there. But what's good is that we are now seeing the cases coming down, and the district council has been working really hard on this. I know Val has done a lot of work with them, and we've done a lot of work on our comms. So.
Thanks, Liz. Thanks, Liz. Great. Raj, is your hands up? Is that to do with this?
Yes, just to say that I've just come off a supportive call with one of the schools where we've got an outbreak in Finland, where we've had 14 cases. So that may explain some of it.
Okay.
We may have to close 2 years.
Okay, thank you. Val, you're waving now.
Yeah. Yeah, I know. Sorry, I forget about waving sometimes, and I start to talk and I forget about putting my wave up. But there you go. Yes, I think just to support what Liz is saying, the majority of work with workplaces at the moment is very much focused in Finland, and it is in those very important food supply factories. And we've seen increases in school outbreaks and obviously community outbreaks as well. So it's quite a complex picture there. But I do think, like for instance, a week ago, I had 7 workplaces that presented with cases and outbreaks. So I think that probably counts for a substantial proportion of the cases.
Yeah. Okay, thanks for that. And thank you, everybody. Finally, Jeff.
Thank you, Chairman. Well, obviously share everyone's relief that there is a approved vaccine now. I just wondered, sort of looking ahead, and I'm just checking online. I mean, there's still a debate around whether vaccination would ultimately be mandatory or not. But even if it's made mandatory, one of the problems would be that I guess the people that, I mean, given the lengthy time of the logistics that it would take to get everyone vaccinated, the sort of people who are going to kind of skip their appointment and, you know, you have to track them down and try and get them booked in again are the very same people that are probably not so particular about following the rules that are in place at the moment. So I just worry that the vaccine won't be as effective as we hope it will be in terms of reducing the R number, because the very people that should be vaccinated are the ones that will kind of avoid it till the last moment. And I suppose also, and maybe this is a sort of matter of national policy, but at some point there'll become a sort of tension between vaccinating the people who are most at risk in terms of their health outcomes should they get the virus, against trying to sort of suppress the vectors of the virus who are kind of going to be the younger age group. And I wondered if we need some sort of, or possibly this has already been thought about, I'm sure, you know, there's a health education thing that we need in tandem.
Yeah, thank you. Liz, do you want to come back on that talk, please?
Yes, and that's an interesting question. And clearly the Joint Committee on Vaccination and Immunisation do highlight those groups that they would prioritise. And I would say at the moment that is very much the health and social care workers, and then looking at those who would have the worst outcome from COVID. So at the moment, it's not the first priority is not that sort of wider population spread issue. And I think that will probably continue. So I think just coming back to the local authorities, one of the things that local authorities and also voluntary sector that we sometimes commission may be able to support with is some of those very close links with communities, and particularly communities that may have some challenges. Maybe they're not that linked in with the mainstream media. There may be language issues or literacy issues. I think that we have very good links with some of those communities and can actually help to promote the vaccine and ensure that people understand the need for it, feel supported, and have that communication with people that they trust, so that they do want to go and get the vaccine. So I can see that as a role for some of the services that both upper and lower tier local authorities are very much involved with.
Yeah, thank you, Liz. I've got hands by Raj and Val. Did you want to come back?
No, it's sorry, I'm not very good at putting them up or taking them down. I'm sorry.
Raj,
Sorry.
is your hand up an old hand? Raj has left me. She's left the hand up. Thank you, Raj. Okay, thank you, Liz. We're asked to acknowledge and comment on your report, and we have. Thanks very much for you and the team who are working incredibly hard. I know. Members, can we please move forward now to item 8, which is the business planning paper. The main report was included in the agenda pack, but the appendix was circulated last Friday in an email and subsequently obviously published onto the website as a later edition. We have Liz. Do we have Stephen? Oh, there you are, Stephen. Hi. Okay, Liz, you or Stephen, do you want to start, please?
I'm happy to start, and I would just say I will thank you for your thanks on the COVID work, and I will pass that on to the team and all those involved. So
thank you.
I want to say that, and it does give people such a boost when they hear that a committee like this in public has acknowledged the work. So certainly do that. And moving on then to the topic of business planning, just some key points, and Stephen may well want to come in on some of these. Sections 1 to 6 really focus on the corporate business planning and the overall processes and issues for the council. So I won't speak to those. I will take you straight to section 7 on page 31 of your pack. Which really focuses on the public health issues. So the public health grant that we have this year is approximately 27.2 million. And that is an uplift that we actually received this year of 1.7 million. So we did have quite a significant rise. Of that, we're required to fund the NHS pay rise over the past 3 years, which the Department of Health and Social Care had previously been funding. That takes about 570,000. And then there was some other commitments where the council had been funding some of the public health programmes after we'd had a series of reductions in funding. The council had picked some of that up, and we're now able to fund that from the grant. And there was also some internal inflation. So by the time you take all of that out, there's about 928,000 that we have not planned for currently, because the announcement of this new rise in the grant came after COVID had started. So we have not had the time to do this year to suddenly business plan for that money. And although we have done a lot of planning and service development, that's actually been funded largely by the COVID grants, the Test and Trace and the COVID Outbreak Management Fund. So we have to put hands up and say we haven't planned for a lot of that. We have put some of it into funding out of our revenue expenditure projects that would otherwise be funded from reserves. And so we're not using up our reserves unnecessarily. And we have also put some funding into some of the COVID related areas. But that means that as we look forward into our next year of business planning, we still need to allocate that funding in a way that the committee wants and is happy with. So the proposals that we've brought forward, just to run through them quickly, are firstly the 70,000 into child and adolescent mental health counselling that you approved at your last committee meeting. That needs to be taken out of that growth funding. 400,000 into implementing the outputs of the work that you have agreed on healthy weight. You've agreed to bring someone in to really look at how we can influence healthy weight through the council's wider policies and services and through evidence-based interventions. So setting aside 400,000 to take that forward next year. We then propose to put 300,000 into increasing public health staffing. And really that is learning from COVID, because what's happened with COVID is we've had to take extra staff on because there's so much public health specialist advice and input that is needed. A lot of that is needed right around the council and also our district council partners and other partners. So we've really built relationships around directorates and also got to know some of their work much better, because we've had to get into the real detail in order to advise on the COVID safety and what we need to do. And I would say that is with our district colleagues as well. It is this one team. So what we're proposing is, with some of the extensions in hours and additional posts that we've invested in with COVID money, and this isn't all of it, this is just part of it, but we want to sustain that going forward so that we can be giving that same advice into, say, the Adults Positive Challenge programme or the Best Start in Life programme, which we were doing before COVID, but we've realised, I think, the amount of detailed work which is needed, and that you get so much of a better result if you've got the capacity to do it. So we've had very positive discussions with the joint management team at the council around how we need to structure this together. Because we really want to make it work. It is health in all policies, and other directors are keen to get involved and understand how we can use the public health input. And to be honest, that may also enable us to deliver some functions like evaluation, evidence-based, that we some directorates may have to buy in at the moment. So that is what that investment is about. We then are very aware that we have not been giving our providers uplifts. We have been taking cash out from most of our contracted services due to the previous changes in the public health grant. And the one that we feel has been most impacted is the drug and alcohol service, in terms of, although they've been very good about making changes in order to make the savings that we had to make. We think that negotiations around how we could improve services but also put some investment back in would be very helpful. So we're talking about provider support, but that there's a particular focus on the drug and alcohol there, but with some flexibility, we think, because this has applied to a number of providers. And then you have seen evaluations of the Healthy Fenland Fund. It's very well embedded. Has actually done a lot of good community work during COVID, and we fund about 30k a year of that team from reserves, rather than having it as solid recurrent funding. So the proposal here on Healthy Fenland is to make that 30,000 recurrent, and also to link it up very closely with our Think Communities approach. So again, that is of benefit. I think I'll stop there, because that's a good run through our proposals, and ask for your comments and questions.
Members, are there any questions to Liz on our budget of spending more money? Linda Jones, please.
Thank you. Yeah, well, I'm delighted that we can finally spend some more money. It's something we've been banging on about as a committee, worrying about our public health team, worrying about the stretch that they've had to, the elongation of limbs in order to reach out and do more and more and more work. And I'm delighted that the team can be strengthened. I think what's also, and as we said, there aren't many positive outcomes from COVID, but I think also the clear message it's sending, which is the importance of public health across the whole of council services, is very clear. And I think to match that by putting this level of investment in, not just to healthy weight, which is clearly a health in all policies approach is going to be necessary to deliver that, but also in terms of adding to and sustaining that a bigger staff group, and particularly at senior level, because influencing other parts of the council is going to be, and other parts of the system is going to continue to be important. And when the kind of emergency of COVID has disappeared, what we don't want to happen is that the kind of silos, if you like, reappear and the joint working is abandoned. So I think this investment is very timely, and I'm very supportive of it for the future of health and all policies right across the council and the system.
Thank you, Linda.
Thank you, Linda. I'm not sure if that needs an answer, but I agree with I agree with everything you said.
It was just, it doesn't need an answer. It was simply a sort of statement of congratulations on the team getting this far. And
I know, yeah.
Yeah, the comment is getting this far in the midst of doing 100 other things as well.
Yeah, great. Thanks for that. Lorna, please.
Thank you. As Dr. Robin said, the first pages of this are sort of corporate pages and not really issues that are answerable by the health team. But I have to just make one comment on that, which was that I was very surprised, and perhaps it's just me not understanding this properly, by the bottom of page 21 of the agenda bundle and the top of page 22 on 2.2.2 on benchmarking, that it was talking about delivering excellent outcomes for its residents, which didn't seem to be borne out by the table of benchmarking information on the following page, which was talking about average, or in a couple of cases, very low. And that didn't seem to cohere for me at all, but I acknowledge that that's a corporate thing rather than something requiring an answer from Dr. Robin. It's not within our purview. It just surprised me. We've certainly had acknowledged, haven't we now, that the adult social care precept is 3%, which I think wasn't known when the paper was written, although there is some suggestion, albeit uncertain, that that could be deferred, and that the general council tax limit is now 2%. So that's sort of an update, isn't it, for us? My question was about the spending on healthy weight and obesity programs. We talked about the 80,000 last time. Is the 400,000 here inclusive of that 80,000, or is it 80,000 plus 400,000?
The 400,000 would be for recurrent investment or we would expect it to be largely for recurrent investment in programs. So the 80,000 is very specific around ensuring that development work is done to understand the best next steps, and the 400,000 is to invest in those steps. So that might be in other directorates, it might be across external providers. We don't know yet because we haven't done the work, but it is separate, and it would be looking for that to be a recurrent commitment.
Okay, thank you.
Thank you. Thank you. Sorry, Susan, please.
Yeah, I think Lorna's asked my question. I'm just picking out there were a bit in the text on the 400,000. I just wonder if, for the record, it needs to be made clearer. There's a bit of it can be a little confusing as to the special role that we're seeking to bring in, and then the interventions, or rather the target investment to be most effective interventions. But maybe that's just me. But I think you've clarified that, Liz, in your answer to Lorna's question, so that's fine for me.
I can put it in the minutes anyway. Sorry.
Rob, sorry?
I can put it in the minutes anyway. I will put it in the minutes so it's clear.
Thank you. Thank you, everybody. So if we could go, please, to what we're asked to do, the recommendation. We're asked to note the progress made to date of the development of business plan 21 to 26, note the impact of COVID, which we have done, and the most important, endorse the budget and savings proposals that are within the remit of the committee as part of consideration of the council's overall business plan. If anybody's not happy with one of those or all of them, could you please show Lucy Lucy?
Sorry, Peter, I just think, given that it's this stage in the business cycle, I would prefer to abstain on these proposals rather than vote for them, because our group will obviously be wanting to do some work on the budget between now and the committee. There's nothing in these papers that partly because the proposals seem very sensible, but I'd quite like to be able to look at the budget as a whole.
Yeah,
so
I get that.
I will just abstain on this one, thank you.
I understand, I totally get that, but we're only asked to note the progress.
I think we're also asked to endorse the proposals. I mean, if the committee's happy to note it rather than endorse that.
If I could just say, we'd endorse the budget proposal for this committee, not for the council. It's for the health committee. So what I'll do is what I often do at this time of year. I'll look at recommendation E and change the wording. So we could look at, we endorse the budget of the health committee as part of the consideration of the council's overall business plan. Just those words, because there's no savings as we're spending money, and it's the budget of this committee of what we just spoke about, the expenditure that we're endorsing to the GPC. Would that make you happier?
Yes, all right, go on then.
Right, very kind. Thank you. Rob, did you get those words, my friend? Yeah?
Yes.
Great. Okay, so if everybody's happy with that, particularly with my rewording of recommendation C, if you're not, just show your hand, please. No. Okay, that's great. So that's pushed out. So thank you very much. Thanks, Lucy. Okay, thank you. Also, a thank you for Stephen for attending. Thank you.
Thank you.
Councillor Hudson, I think you're on mute. Sorry.
I'm having mouse problems. I'm sorry. Yeah, I think it's okay. Yeah. Okay, so we've read the agenda plan as published. This is item 9, pages 37. I don't think there's anything to add, Rod, is there?
Nothing to add, as you'll be discussing at your next chairman, vice chairman and lead members meeting the final version of the agenda for February. Just as we're fairly certain it will be a virtual meeting in February, and as you have 2 scrutiny items, it's currently listed as that, looking at the reports listed and the same as what you did at the last meeting to keep the agenda to a manageable size, do you want to consider which, if I sort of list 3 of the following that the committee are going to receive, whether they could be sent by email rather than included on the formal agenda, and I'll take guidance from the committee. That would be the ones: trend analysis of the impact of the first COVID-19 wave on childhood vaccinations, the further report on the actions being taken to support young people and families during COVID-19, and as has been the case in the last few cycles, the finance monitoring report.
Okay, thank you. Linda Jones.
Thank you. I haven't got any issues with those, but it did strike me that we've just agreed that we will support the spending of 400,000 and then another 130,000 on issues relating to staffing development across the council and on the Healthy Weight programme. And if we're going to start spending out in a timely way, there obviously has to be work done in developing that. And I wonder if there needs to be a very short paper to the committee fairly soon, perhaps in February, which actually outlines the key work that's going to be done with some timescale. Because, that'll have to be done anyway, but it'd be good to keep the committee informed.
Okay, we'll look at that, Liz, yeah? And
that's fine.
Yeah. Okay, Linda, thank you very much for that. So we're all happy for those three documents to be sent to us on email outside the formal meeting. Any questions or any comments you need to make on them, please do, and copy all the committee in so we can still have a committee discussion, but without being in a formal committee setting. That's great. So Liz and Val, are there any changes or updates you want to give? No?
No, thank you.
No? Good, thank you. I'd just like to bring something else to the attention of the committee, please. Rob Sanderson, if you look at him, he's going to retire. Now, a man who looks that young with that amount of hair is of an age to retire is an outrage. But I would like to thank Rob on behalf of you all, and personally, he's been a great help to me. He's looked me in the eye and said, "You may want to do that, Councillor Hudson, but you can't." He's been fantastic. Rob, I'd like to thank you for all your work, all your support, your great sense of humour, and all the help you give to this committee. And I hope you have a very, very, very relaxing, but I don't suppose you will, retirement. A big thank you to you all. Thank you.
Here, here.
Here, here.
Okay, so the next meeting is on the 11th of February, unless something happens, we need to call you in. So that only leaves me to thank you for your attendance, as always. And this is our last meeting before whatever form of Christmas we're all going to have. But whatever Christmas you have, please have a happy one. And I really hope next year is a bit nicer, that I can actually touch one of you. It'd be lovely. So until then, thank you very much indeed. Meeting over.
Merry Christmas.
Take care. Merry Christmas to everybody.
Merry Christmas. Bye.
Bye. Merry Christmas.